You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by Marcelle Kaplan, a breast oncology clinical nurse specialist and a member of the guidelines panel that developed the new ONS Guidelines for cancer treatment-related hot flashes in women with breast cancer and men with prostate cancer, to discuss hot flashes and how to manage this symptom of cancer. A previous episode highlighted ONS's symptom management guidelines, so we suggest you first listen to that podcast, linked in the episode notes, if you are unfamiliar with the changes. Thanks for joining me today, Marcelle.
Hi, Stephanie. I'm so pleased to have this opportunity to speak about the new ONS guidelines for managing treatment-related hot flashes in women with breast cancer and men with prostate cancer.
Just to get us started, why don't you tell us a little about yourself, your work in oncology, and your role in developing the ONS guidelines for hot flashes?
I've had a variety of clinical and leadership roles over the year in oncology nursing. I volunteered to join the hot flash PEP team, which is putting evidence into practice, and was formed by the Oncology Nursing Society in 2009 to evaluate evidence-based interventions for managing hot flashes in patients with cancer. And early on, we had to decide, which are the patients we're going to focus on. And we realized that the patients whose cancer treatments most often result in the development of hot flashes were women with breast cancer and men with prostate cancer. And also, very importantly, we needed to investigate these cancers where there was a sufficient body of literature that described evidence-based interventions for managing treatment-related hot flashes in our population. So that was a process to narrow it down to the two populations. And over the years from 2009, we reviewed and critiqued evidence-based interventions as high quality as we could and published it in both the Clinical Journal of Oncology Nursing, that was published in 2011, and also 2014. And I must say that without the library staff, I don't think we would have identified all the new studies that were being published. So I would say that the experience with the PEP process over the years helped pave the way for the development of the ONS symptom management guidelines. And that developed Pam Ginex, who's the senior manager of evidence-based practice and inquiry at the ONS. She is the guiding light in this whole process of developing ONS symptom management guidelines. And she chose hot flashes to be the first guideline to be developed and released. So just a little bit about how the guidelines were developed. It did take about 2 years. It was a multi-step process that began when Pam put together a very collegial panel of it was both multidisciplinary and international panel of experts to serve on our hot flash guidelines panel. We had a physician from South Africa. We had a nurse from Barcelona, an oncology pharmacist from Houston, oncology nurses from across the country, patient representative, and ONS staff members. And probably most crucially, apart from Pam's membership, we had a panel member who was an expert in the process of developing healthcare guidelines using a standardized methodology called GRADE. And GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. Guideline development is very lengthy and complex, and Pam has described that in a prior podcast episode, which you're linked to, called ONS Guidelines Will Answer Key Symptom Management Questions. So I wanted to provide a sense of the series of steps that took place over the years to culminate in development of this guideline.
Thank you. That's very helpful in helping folks who may not have known what the development process and kind of where this came from to explain that for us. So what are some of the breast cancer therapies, either drugs or surgery, that can make or cause hot flashes in patients?
Well, treatment-related hot flashes are common in women with breast cancer, and the estimates actually of their prevalence range from about 51 to 81% of women who are treated with hormone depletion therapies. So in general, treatment of breast cancer depends on whether the cancer cells contain receptors, an overabundance of receptors for estrogen. And one of the treatment methodology is to starve those cancer cells of the hormone estrogen. So the women are administered or advised to take methods to reduce cellular exposure to estrogen, which include for women who are postmenopausal and were taking hormone therapy, which used to be called hormone replacement therapy. So they have to stop it. There's also drugs that they take to suppress estrogen production and cause estrogen withdrawal. And these drugs are taken for years and include tamoxifen, which is often used for premenopausal women, and or aromatase inhibitors, which is typically used for postmenopausal women. And so the abrupt depletion of estrogen, which is the treatment goal in women who have estrogen receptor positive cancers, precipitates the onset of hot flashes. In addition to hormonal manipulation, chemotherapy regimens used to treat breast cancer can be toxic to the ovaries and induce premature menopause in younger women. And these women with chemotherapy-induced menopause, they experience a sudden reduction in estrogen, and they have increased frequency and severity of hot flashes in comparison with healthy women whose estrogen levels decline gradually during the normal aging process as they become menopausal.
Okay, what are some of the prostate cancer therapies nurses should be aware of that could lead to hot flashes?
Well, a lot of people may not be aware that hot flashes can occur in men who are treated for prostate cancer with certain therapies. And it's the same etiology as women with breast cancer, the abrupt hormone depletion. And in that case, it's the depletion of testosterone. And this type of therapy is used for men with advanced or metastatic prostate cancer. They are treated with what's called androgen deprivation therapy, also called ADT, which is used to starve the prostate cells of the hormone testosterone that fuels cancer cell growth. So androgen deprivation therapies can be achieved through the use of drugs or surgery. If drugs are used, anti-androgen drugs, they induce what's called a medical castration. If the testicles are removed in the procedure called an orchiectomy, that is called a surgical castration. But in both instances, you have an abrupt cessation of hormone production. Men may also be embarrassed to share that they have hot flashes, but almost 80% of men treated for prostate cancer with androgen deprivation therapies, whether it's drugs or orchiectomy, are reported to experience hot flashes, and these hot flashes may persist for years. So I would say the nurse caring for these men may be able to gently broach the subject of hot flashes, asking they may not volunteer that they're experiencing hot flashes, but maybe gently ask if they have hot flashes and they can provide reassurance that hot flashes are common in men receiving ADT therapy, and that there are some interventions that may help diminish or prevent the hot flashes.
That is really interesting and something probably that folks may not have thought about during, while they're administering their treatments or talking with patients about their treatment. So that's a really good piece to, keep in mind as we're working with patients that have these diagnoses. So interestingly, there's always the discussion of which intervention for hot flashes is better. But what do the guidelines document about using interventions versus no treatment?
All right. Well, that's an interesting question. And before I give some specific examples, I just like to, I'm doing a lot of description of how we arrived at the guideline because this is the first one and it was an exciting process and people, nurses and most people are probably unfamiliar with how it started and how you arrive at your final recommendation. So first the group, the hot flash panel, we had to sort of decide how we're going to focus on identifying research studies relevant to our two patient populations. And we formulated an overarching question, clinical question. What are the non-hormonal, pharmacologic, physical, behavioral, and natural health product interventions that minimize the frequency and severity of hot flashes and the negative impact on quality of life in patients with breast or prostate cancer? And it's a lot to take in verbally, but the guidelines and clinical summaries are published in both CJON and ONF, and I'll speak about that later. So once we had our question, we could identify studies that were relevant to the question, and they were assessed for the certainty and quality of the evidence they reported using this grade process, grading of recommendations, assessment, development, and evaluation. And the grade method is being increasingly used by healthcare organizations around the world to produce rigorous and transparent clinical practice guidelines. And they're transparent because all the studies that were examined, that were reviewed and synthesized are included in a document. So you see where it came from. So this method was totally new to everyone on the panel. So we were fortunate that we did have our expert member, and she gave us all an online tutorial about how grade is used to collect and synthesize evidence, even if the evidence is pretty sparse, which frequently it is, so that we could arrive at the best recommendation according to the existing evidence that we had. So, in answer to your question, based on the results of the grade approach, we were able to either suggest, we didn't recommend, and I'll describe the reason for that. The quality of the evidence was what we call conditional. There wasn't a lot of evidence, and it was either determined to be the quality low or very low. So we could only suggest, rather than recommend, that certain interventions could be useful for managing hot flashes rather than giving no treatment, or suggest against an intervention. So I'll give you some examples. So pharmacologic recommendations for women with treatment-induced hot flashes, women with breast cancer with treatment-induced hot flashes, suggest using venlafaxine, paroxetine, or clonidine rather than no treatment for the management of symptoms. Or another one, for men. Pharmacologic recommendations for men with prostate cancer suggests paroxetine or clonidine rather than no treatment for the management of symptoms. There were 14 recommendations, so I'm just giving you a sample. So another recommendation that applied to both women with breast cancer and men with prostate cancer suggests against using the drug gabapentin for the management of symptoms. And this recommendation differs from some other published guidelines, but it is based on the evidence of serious side effects in certain groups of people who are taking gabapentin. And in the non-pharmacologic category, for both women and men, panel suggests against herbal or dietary supplements, such as soy, black cohosh, which used to be a big thing, St. John's wort, melatonin, vitamin E for managing symptoms. And then there were others because the evidence was really limited. So we said we couldn't support a recommendation because of a knowledge gap. So we recommended their use only in the context of a clinical trial. And this was for such interventions as, non-pharmacologic interventions as acupuncture, hypnosis, relaxation therapy, and cognitive behavioral therapy. That's what we found.
Okay, that's a lot of information, and that was really a lot of in-depth research and discovery on how to go about making those recommendations on what treatment or intervention should be used. Why was that an important inclusion for the guidelines?
Well, basically, in formulating the guidelines, we came up with 14 recommendations based upon the synthesis of the evidence. But in general, with our topic, the strength of the recommendation for each type of intervention was rated as conditional or even no, that we couldn't make a recommendation because there was a knowledge gap. And that was also conditional because the certainty of the existing evidence, the quality of the trials, the lack of clinical trials, the small sample sizes, the short follow-up, the certainty of the existing evidence was either low or very low. So we synthesized it. That's why the grade method is perfect for synthesizing the evidence and combining evidence into meta-analyses based on putting all these studies together and arriving at a recommendation. So that's why it's important.
So what do the guidelines say about the role gender plays in determining pharmaceutical interventions?
All right. Well, the guidelines panel did develop separate research questions for women with breast cancer and men with prostate cancer who are experiencing drug or surgery-induced hot flashes. And we reviewed the relevant evidence-based studies for each gender. So some of the recommendations we could only pertain to women. And not surprisingly, we found many more studies researching treatment-related hot flashes in women with breast cancer compared to men with prostate cancer. So ultimately, we found some similarities and differences in the suggested interventions based on gender. For example, the guidelines suggest that women use the drugs venlafaxine, paroxetine, or clonidine, but for men, the suggestion is for paroxetine or clonidine. The use of venlafaxine in men was rated no recommendation due to a knowledge gap, and we said that it should only be used in the context of a clinical trial. And for both men and women, we said physical activity interventions, exercise or yoga, was suggested over no treatment for management of symptoms. So we did consider gender, and it differed for men and women in certain contexts.
Okay. What does the guideline document say about the role of tamoxifen in determining pharmaceutical interventions for hot flashes?
I'm glad you asked that question, Stephanie, because tamoxifen is an important hormonal therapy used for breast cancer, usually with women who are premenopausal, but it's known to cause hot flashes that could be frequent and severe and so distressing that many women may discontinue tamoxifen therapy due to the distressing side effects. So this is a patient population that will likely seek relief for the hot flashes. However, it is really important for the healthcare professional who sees these patients to determine whether a woman being treated for breast cancer is taking tamoxifen before suggesting any pharmacologic interventions. Specifically, referring to the use of certain antidepressant drugs that are suggested by the guidelines, and these are the drugs paroxetine and fluoxetine. But they come with an important caveat for anyone who is being treated with tamoxifen. These patients should be advised not to take the drugs, paroxetine and fluoxetine, to manage their hot flashes because the drugs are strong inhibitors of the enzyme system CYP2D6 that is important in tamoxifen metabolism. And thus, these drugs will interfere with the effectiveness of tamoxifen. So the use of these drugs is contraindicated in women taking tamoxifen.
That has to be frustrating for them to know that, the medication that they're taking is causing the hot flashes, but also the intervention would be counterindicated as well. And so I can see why, you might have that problem with patients deciding that they just can't stand the side effects any longer and they're going to stop their treatment, which, is not the best idea for them to do. But, when they're looking at their quality of life and how they're dealing with that, that would be just a really difficult thing to be able to work through with our patients. So patients are unique and might not respond to the same interventions. What process should nurses keep in mind when looking at these guidelines and considering intervention?
Well, totally. Every patient is unique and different, and some patients might prefer to take a pill. Others might prefer to avoid drugs and their potential side effects, instead prefer to learn about non-pharmaceutical methods to help relieve hot flashes. So the guidelines, the way I would say when a healthcare professional, oncology nurse is looking at the guidelines, probably makes sense to look at the clinical summary of the ONS guideline for cancer treatment-related hot flashes in women with breast cancer, men with prostate cancer, and that appears in the August 2020 edition of the Clinical Journal of Oncology Nursing, because I think you have to see it, and it gives a simple table, an overview of how the guideline was developed and the clinical practice recommendations, and they're summarized in a very simple and I think reader-friendly table. Anyone who wants more detailed description of the guideline process and recommendations, that appears in the August 2020 issue of the Oncology Nursing Forum, which just recently came out. And as I've mentioned, in reviewing the guidelines, the nurse will find 14 recommendations for managing hot flashes divided into both pharmacologic and non-pharmacologic interventions, along with the ratings for their strength of the evidence and certainty of the evidence, as well as interventions that there was no recommendation because of lack of evidence was too great. Pharmacologic recommendations are divided into recommendations for women and men, and some are for both. The non-pharmacologic applies to both.
Along with highlighted recommendations for interventions, the guidelines also highlight interventions that are not recommended. What do those entail, and why were they important to include?
Well, they are important, and I'll tell you, the guideline development process reveals some interesting findings about the harms or lack of evidence associated with some interventions that have been touted over the years anecdotally for managing hot flash symptoms. So, for example, we concluded that we had to suggest against the use of gabapentin for managing hot flashes in both women and men because of the reported adverse side effects. The evidence did not support us recommending for it or suggest using it. No, we had to suggest against it. We also had to suggest against using herbal or dietary supplements, soy, black cohosh. You speak to some people, they'll think, oh, black cohosh, St. John's wort, melatonin, vitamin E, because the quality of the evidence was so low, the benefit was lacking, and there were unknown or potential harms. Then there were certain interventions we couldn't make any suggestions for or against, such as cognitive behavioral therapy or acupuncture or relaxation therapy because of the lack of evidence. And we recommended that they only be used in the context of a clinical trial.
Well, as you're talking about all of these interventions that did not have evidence to support to be placed into the guidelines, does the guidelines say anything about some areas for research that could be looked into for hot flashes?
Well, I would say yes, because our work in the areas I just mentioned, which we couldn't make a recommendation about because of knowledge gap, lack of evidence. So that's studies, for instance, the antidepressant venlafaxine for managing hot flash symptoms in men with prostate cancer, even though we suggest for it in women with being treated for breast cancer. Also, behavioral interventions such as hypnosis or relaxation therapy, cognitive behavioral therapy. A lot of times, that's touted as being effective, as well as acupuncture. These are all areas that lend themselves to further research, and I would think to research by nurses.
That's great. I think that is a really good point to bring out, Marcelle, is that those are areas that can be looked into and researched by nurses, and, looking at symptom management as a research area for nurses to kind of, take the reins in and work on and start doing to help our patients improve their care and their quality of life and things like that. So if listeners want to find more information about the new ONS guidelines, where should they look?
Well, I would assume that the information, or hopefully the information provided in this podcast, can whet the appetite of people who are listening to get the details. And for a fuller description of the guidelines, I think the clinical summary in the August 2020 issue of the Clinical Journal of Oncology Nursing would be a good place to start. And actually, that is an open access article that's available to anyone. And that's, lays it out simply and the most cogent points that we discussed. Now, for the full guidelines and the systematic review, that appears in the July 2020 issue of the Oncology Nursing Forum. That you would have to be a member to access, or I guess pay for it. And ONS also has website for the guidelines in general and for hot flashes. And at ONS Bridge in September, there's going to be a presentation on guidelines.
Excellent, that is. And I really like the idea of the article that's coming out in the CJON, just to really help the clinical nurses have that evidence-based practice and to incorporate evidence-based practice into their personal practice with their patients. And then, going on to get more information and looking at the full report in the forum. So just to wrap us up today, do you have any final comments about the new ONS guidelines for hot flashes, their role in patient care, or anything we might have missed?
Well, I just want to say, I have to share some thoughts. So as a reminder, I want to stress that these guidelines are specific, I know we all know this, to patients with a history of hormone-dependent cancers. So we reviewed only studies that pertain to managing therapy-induced hot flashes in women with breast cancer and men with prostate cancer. So you cannot say that our findings pertain to the general population of postmenopausal women. It's those women, actually. Estrogen replacement therapy is considered the most effective therapy for mitigating hot flash symptoms, but that would be contraindicated in our population. So I want to say that we found there was an interesting finding from several good quality randomized clinical trials that included an active intervention arm and also an arm where they gave placebo. All right, and they compared the placebo intervention with an active intervention, and in about 30% of the subjects, when you combine the studies, 30% of subjects reported better responses to the placebo than to the active intervention. So I think that's the placebo effect, and that's a consideration I think that should be kept in mind when reading study results. And I think that could apply to let's say, studies where you have one-on-one interaction with a healthcare professional, like cognitive behavioral therapy, where you meet weekly, or other therapies where you're actually having an interpersonal interaction. So my feeling that could increase the placebo effect. And then there are many tips in the popular literature regarding behavioral changes to help manage hot flashes, such as dressing in layers, avoiding hot beverages and spicy foods, sleeping in a cool room. But these are anecdotal. The evidence is lacking to validate their effectiveness. So I think this can be an area to study that nurses can study that lends itself to nursing research. So that could be a good thing.
Well, thank you so much, Marcelle. This has been very enlightening and has a lot of information for us. And we are very excited for these new ONS guidelines to be coming out to help improve symptom management and different cancer-related treatments. So thank you for your time today.
Thank you for giving me this opportunity.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.